Hey everybody, welcome back to the ECG of the day. My name is Reid, and before we get started with the ECG, go down to the description and download this copy so that you can follow along yourself, and like and subscribe if you enjoy the content. So let's jump into it. So the first thing I like to do is just kind of scan through the ECG. I call it looking at the forest, and the trees of the forest are my QRS complexes. The first thing I notice, maybe I choose lead 2 here, is that we've got a regular rhythm that's tacking along. Seems to be a normal rate. It's a wide complex. It appears to be wide. And then all of a sudden it changes, and I'll change it in red, to this more narrow QRS for a few beats. And then we see it transition back to the wide. So we've got a couple different morphologies of our QRS, but the rhythm seems to be pretty regular here. If I look at the rate of our QRS, maybe I'll choose this one that lands on a solid line, and we'll count 300, 150, 100, 75. So somewhere between 75 and 100, maybe roughly 80 beats per minute. So we've got a normal rate here. Seems like we might have some P waves in front of our narrow QRSs, but it's hard to tell what we see in front of our wide QRSs. So let's take a look and see what we think's going on. So first thing I'll do is, we're gonna have to maybe adjust our approach to this ECG just a little bit, because we're not just gonna go jump straight to the atrial activity. We might do that for our wide complex QRSs. So I'm gonna zoom in on these wide complex QRSs. They're occurring at a rate of, say, 300, 150, 100, 75, maybe 80 beats per minute as well. And what I notice is that when I look in front of them, I don't necessarily see any P waves, right? I'm going to scan through multiple leads and look for atrial activity. And so I can go through here and go through here. I can even go up to lead 1, and I don't necessarily see any P waves. And so I might look through these wide complex QRSs over at the end of the strip. I don't see any regular P waves. There seems to be a P wave here, but it doesn't look like that conducts to that QRS. That's a P wave that's a little bit too close to that QRS. So maybe this P wave isn't so relevant to that QRS. And so in the setting of a wide complex QRS with no atrial activity that's driving it, we would say that these wide complex QRSs are ventricular in nature. And if that's the case, then we've got a ventricular rhythm at a rate of, say, 80 beats per minute. And so that is an accelerated idioventricular rhythm, or AIVR. And so essentially what that means is that somewhere within the ventricles there is a focus, and it's firing off and it's spreading slowly from cell to cell gap junctions, not taking the normal His-Purkinje system, and it's firing off at a rate of around 80 beats per minute. And that's our accelerated idioventricular rhythm. And then all of a sudden we get this narrow complex rhythm that takes over. And what I notice is that in front of our narrow QRSs, we've got these P's, right? So we've got a P wave, and so what is going on here? Well, we've got this P wave that's causing narrow depolarization, and the AV node here seems to be my PR interval, seems to be right around the upper limit of normal, so that's a normal PR interval. And so we get this for roughly 2 beats. So we have 2 normal beats of sinus beats here at a rate of roughly 80 beats per minute. And then we have kind of this funky beat. This beat right here is kind of a funky beat. So if you look at this beat, it doesn't resemble exactly the narrow complex QRSs, and it doesn't exactly resemble our wide QRSs. And so what I think is going on here is the sinus node, this person, the sinus rhythm, if you measure the P to P interval, so the P to P interval here, if we measure that out, notice it's a little bit shorter than if I measure the P to P interval to the next P wave. It's a little bit of a longer interval. And so when this P wave here conducts to this QRS, we get something called a fusion beat. And a fusion beat occurs, essentially, if I go to my diagram, this person's got a sinus rhythm. I'll erase this a little bit. This person's got a sinus beat. And the sinus beat is coming from this AV node here. It fires off, depolarizes the atria, and as it's working its way through the AV node to get down into the ventricles, this focus that we said was driving the AIVR rhythm fires off, starts to depolarize the ventricles at the same time that our signal comes down the His-Purkinje system. And so you essentially get a fusion of those two complexes in this hybrid type of beat. It's a fusion beat. And then we see the resumption after the fusion beat of the accelerated idioventricular rhythm. And notice during the accelerated idioventricular rhythm, we do not see atrial activity that is driving that rhythm. And so what is going on to cause this? Well, likely what's happening is this person, as they breathe, there's something called sinus arrhythmia. And sinus arrhythmia is a change in the heart rate when we inspire and expire, because changes in inspiration and expiration change the pressures in our thoracic cavity. It decreases and increases the blood flow that returns to the heart, and so the heart will actually adjust its heart rate based on the preload, or how much blood it needs to pump in and out. So what we're seeing here is when the sinus node slows down, so here, during this first portion, the sinus node slows down. And when that happens, this focus that's in the ventricles takes over because it's firing. Its intrinsic rate is a little bit faster than the sinus node at that point. And then you see the sinus node here in red picks up its speed. And so here we get an increase in the sinus rate, in the SA node rate. And because of that, we see that it can overcome and start to capture the atria, and then through the AV node capture the ventricles, because the rate here between these narrow beats is a little bit faster than the rate between these wide beats. And then as that sinus node slows down again, it allows for that focus within the ventricles to take over in an accelerated idioventricular rhythm. So as this person is inhaling and exhaling and their sinus node changes in their rate, then we see this focus, this accelerated ventricular focus that's firing off. And so this person is essentially having a sinus node compete with a ventricular focus. So what does this person need? This person is going to need to get an electrophysiologic study and figure out where that ventricular focus is, and you can ablate it and be done with it. So I hope this helps. It's kind of an interesting ECG here, and we had to deviate from our approach, and that's okay. So hope this helps, and don't forget to subscribe. See you tomorrow. Have a great day.